Hello guys, my name is Felipe. I'm a Brazilian neurologist and today's lecture will be about amyotrophic lateral sclerosis. ALS is an adult-onset neurodegenerative disorder. It is characterized by progressive muscle weakness involving both upper and lower motor neurons. It has an annual patient cost about 32,000 to 78,000 per year. It is the most common motor neuron disease in adults and the third most common neurodegenerative disease worldwide. It has an annual global incidence of 1.5 to 2.5 each 100,000 people and a prevalence of 4 to 6 each 100,000 people. Its incidence increases above 40 years old and peaks between 55 and 75 years old. It has a male to female ratio of 1.2 to 1.5 each one female for sporadic ALS and 1 to 1 male and female for familial ALS. It has an autosomal dominant inheritance. The most common risk factors are older age, male sex, family history, and military experience. And the cause for military experience being a risk factor is unknown. ALS is an idiopathic disease, so the cause remains unknown, but the pathophysiology begins with an unidentified pathogenic factor that travels between contiguous cells and axons in both directions, and then in both upper and lower motor neurons, the TDP43 will displace from the nucleus and cause misplacing of the genes, especially UNC13A and STMN2. The UNC13A will reduce the neurotransmitter release and thus reducing the receptor activation and neuronal communication. The STMN2 will cause lower microtubule production and repair, thus reducing axonal health and growth. The typical symptom of ALS is focal muscle weakness, initially unilateral, then spreading to other muscle groups. In 60% of the patients, it will be starting or in upper limbs or in lower limbs. In upper limbs causing hand weakness and in lower limbs causing foot drop. In 25% of the patient, it has bulbar onset causing weakness of tongue, pharyngeal, and facial muscles causing loss of speech and swallowing. In 10% of the patients, it has abdominal and trunk onset causing stupid posture in the patient. In 5% of the patients, it will begin with respiratory failure. In the physical exam, we will observe both upper and lower motor neuron signs. Upper motor neuron signs will be slowed fine movements, increased muscle tone, muscle spasticity, increased reflexes such as hyperreflexia, jaw reflex, and pathologic reflexes such as Babinski and Hoffman. And we also have upper motor neuron variants of ALS that are both primary lateral sclerosis, PLS, and Mille syndrome, hemiplegic ALS. And the lower motor neuron signs will be flaccid weakness, muscle atrophy, fasciculations, decreased muscle tone, and hyperreflexia. And the lower motor neuron variants are progressive muscular atrophy, flail arm syndrome, and flail leg syndrome. Other features of ALS in 10 to 15% of the patient, we will observe cognitive and behavioral dysfunction. So, inappropriate sociability, apathy, deterioration in language. Eventually, some patients will meet the FTD criteria, because some cases patients will have an overlap between ALS and FTD. Usually this has a genetic cause with the C9orf72 gene. And in 40% of the patients, we will observe emotional lability that we call this pseudo-bulbar affect. It's caused by bulbar upper motor neuron lesion. So the patient will present with laughing and crying, episodically involuntary and uncontrollable episodes of laughing and crying. In 15 to 30%, we will observe other neurologic features, such as Parkinsonism, cerebellar degeneration, such as ataxia and dysmetria, and minor sensory impairment, such as loss in proprioception or vibration, and autonomic dysfunction, such as urinary incontinence and erectile dysfunction. And 50 to 80% of the patient will present with fatigue, weight loss, muscle cramps, joint and muscle pain, depression, and sleep disturbances. ALS diagnosis is based on clinical criteria. So, in a nutshell, this means progressive involvement of upper and lower motor neurons. The clinical criteria today are revised L-Scorial, Awagi, Airlie House, and Gold Coast. The role of laboratory is to exclude odd conditions. So we will be ordering complete blood count, TSH and T4, CPK, CRP, ESR, ANA, RF, B12, anti-GM1, serum protein electrophoresis with immunofixation, ATLV 1 and 2. The role of imaging is to make different diagnoses with other conditions. So if the patient is having bulbar symptoms, we will be ordering brain MRI. If the patient has upper limb involvement, we'll be ordering also cervical spine MRI. In the electrodiagnosis, we will observe active denervation, so fibrillation, fasciculation, and positive waves, and also chronic denervation with large and long voluntary motor unit potentials. It's also useful to exclude other differential diagnoses. Biomarkers are not accurate for diagnosis, so neurofilament light protein in blood has a sensitivity of 71 and specificity of 86, and in the CSF it has a sensibility of 89 and specificity of 96. When talking about the genetic causes, 15% will have family history versus 85% in sporadic ALS. And those sporadic ALS, 5 to 10% are further reclassified into familiar ALS. The genes most commonly associated are C9orf72 is the most common, so it involves 40% of the familiar ALS and 8% of the sporadic ALS. SOD1 will be 16% of the familiar ALS and 1% of sporadic ALS. Both TDP and FUS will be 1% of the familiar ALS. All patients should undergo genetic panel testing and genetic counseling. The genetic panel testing will be or whole exome sequencing or whole genome sequencing. In the differential diagnosis, we have firstly the categories, then the subtypes, then the etiology. When the patient has the typical presentation of ALS, we will divide it in spinal onset ALS and bulbar onset ALS. In spinal onset ALS, the differential diagnosis will be cervical myelopathy, dural arteriovenous fistula, multifocal motor neuropathy, and diabetic polyradiculopathy and myasthenia gravis. And in bulbar onset ALS, MG, X-linked spinal bulbar muscular atrophy, stroke, and facial onset sensory motor neuropathy. When the patient falls in the category of lower motor neuron variants, we have progressive muscular atrophy, flail arm syndrome, and flail leg syndrome. In progressive muscular atrophy, the etiologic diagnosis will be also X-linked spinal bulbar muscular atrophy, SMA type 4, CIDP, motor neuropathy, inclusion body myopathy, post-polio syndrome, benign cramp fasciculation syndrome, Tay-Sachs syndrome, and also MG. In the flail arm syndrome, we have Hirayama disease, monomelic amyotrophy, MMN also, brachial plexiopathy, and in flail leg syndrome, we have lumbar radiculopathy, diabetic polyradiculopathy, and polyneuropathy in general. And with predominantly upper motor neuron variants. We have primary lateral sclerosis, that the differential diagnosis will be PSP, HSP, and MS, and in hemiplegic ALS, PSP, HSP, and stroke. Now going to the treatment of ALS, the main drug is riluzole. It inhibits voltage-gated sodium channels, thus reducing presynaptic glutamate release, thus reducing excitotoxicity and reducing overactivation of glutamate receptors on motor neurons. It has an oral presentation. The dose is 50 milligrams each 12 hours. It slows ALS progression, reduces time to tracheostomy or death, and 58% of the patients will be alive at 18 months versus 50% of the patients in the placebo group in the clinical trials, and also improves survival of 6 to 10 months. The second drug is edaravone. Edaravone will reduce the hydroxyl, peroxyl, and peroxynitrite free radicals, thus reducing the effects of oxidative stress on motor neurons. So it's indicated for patients between 20 to 75 years old with early stage ALS that is defined by a disease duration of less than 2 years and forced vital capacity above 80%. And 24 weeks after using, the patient will benefit by reducing its functional decline in ALS FRSR. It's a score for functional outcomes in ALS. Its presentation is oral with 105 milligrams, that is equally to IV 60 milligrams. But some studies showed negative results with equivalent compound called FAB 122. It didn't slow a rate of functional decline. Our third drug is tofersen. It degrades the SOD mRNA and thus reducing normal and toxic SOD1 in the patient. It's administered intrathecally only for SOD1 ALS, and the functional outcomes of the patient in the 28th week, the patient won't have any benefit, but in the week 52, it has a decreased decline of the functional deficit. The earlier we start this drug, the better. Also, multidisciplinary teams must be involved in the care of the patient. So the patient with ALS has dysarthria and difficulty dressing, eating, walking, and difficulty with mobility. The multidisciplinary teams has its function of improving survival of 4 months in some patients and involves both pulmonary care and palliative care. So in palliative care, we're talking about symptom management, psychological support, and life issues, and family and caregiver distress. The symptom management has some main issues. So, the weakness of bulbar muscles in the patient with ALS will lead to both dysarthria and dysphagia. Dysarthria, we will be using speech therapy in the patient and also recommending assistive communication devices. With dysphagia, we will be indicating diet modifications, so making food softer and easier to the patient can swallow better, softer and thicker, and high calorie oral supplementation, so the patient won't be losing weight constantly. And the other main procedure we can also indicate for a patient is gastrostomy. So the patient stabilizes his weight, prolongs survival, and should be done before the onset of respiratory compromise, typically when the forced vital capacity is above 50%. Then the gastrostomy will have more benefit. In up to 50% of the patients, they will have sialorrhea. So here we can prescribe to our patient glycopyrrolate tablets, scopolamine patch, sublingual atropine drops, botulinum toxin in parotid glands, low-dose radiation to salivary glands, and suction devices with soft-tip catheters. The respiratory function of our patients should be evaluated each 3 months. When is the time to our patient come back to our consultory? And we'll be doing spirometry, and in both supine and standing position, we will be measuring FVC, forced vital capacity, maximum inspiration-expiration pressures, and cuff peak flows. Also in the respiratory function, we can also indicate the non-invasive ventilation that increases survival in 7 months in patients with ALS. So the hypoventilation is defined when the FVC is below 80% with symptoms or below 50% regardless of the patient having or not having symptoms. Or hypoventilation is also defined by maximum inspiratory pressure of below the 60 centimeters of water. When managing the pseudobulbar effect of our patient with ALS, we have 2 main drugs, dexmedetomidine and quinidine, 30 plus 10 milligrams, and low doses of amitriptyline, 10 to 25 milligrams. When managing spasticity, it's defined by a resistance to high-speed passive movement. It happens in 80% of the patients with ALS. The first line of the treatment is baclofen and benzodiazepines, and the second line is botulinum toxin and intrathecal baclofen. The physical therapy, we have its role here with stretching and range of motion exercises. When managing cramps, we'll have mexiletine 50 milligrams each 12 hours that will reduce the frequency of the cramps to 1.8 per day and reduce intensity in 15% of the 0 to 100 scale. When we are talking about prognosis in the patients with ALS, they will be developing progressive diaphragm muscle weakness that will be causing hypercapnic respiratory failure and thus leading to the death of our patient. 10% of the patients survive for more than 10 years. And patients with bulbar symptoms, respiratory compromise and dementia has poorer survival rates. Less than 1% of the patients have symptom stabilization, and the mean life expectancy of the patients with ALS is 3 to 5 years after the diagnosis.